So you're right. I think we're talking about the quick thinking and fast thinking, the nuances and all. So we talk about the great book, the Thinking Fast and Slow. So it talks about system one thinking and system two thinking. So system one thinking is very fast, that fast thinking. The example is, and this is what our evolution supports, is when you are a jungle, let's say you're walking in the dark and you see something, and you it's the danger to you, and you have to make a quick decision, and your eyes want to see what you want to see instead what's real. For example, there's a tiger coming by behind you, and you hear something like a growling sound, then you're like, oh, okay, there's a tiger nearby, I need to run, right?
Mhm,
And the risk versus reward. So you may be wrong 99% of the time,
mhm.
but if you're wrong this one times, then you're dead. Therefore, our psychology, human brain incentivizes for fasting.
Mhm.
So whereas for the slow thinking, that's where like logical thinking, there is a heuristic, right? Heuristic, okay, these are the reasons why I make the decisions, and okay, these are my constraints, this is my context, right? That's a slow thinking. And that is very energy expensive process, right?
Mhm.
Expensive process, and also human body, and the brain takes 30% of the energy it
Mhm.
tries to conserve. Today we are living in an energy abundant environment, but evolutionary speaking, we have always lived in the energy scarcity environment, and our body is incentivized to conserve energy, and
Mhm.
therefore it's all about thinking fast, making quick decisions, and there isn't the place for nuances, and that also keeps get into the uh, the decision making in this our political space or our conversational space, right? We have to put on extra effort to start thinking critically, because it's energy intensive, and it's actually opposite of our evolutionary development.
Yeah, well, what developed first, right, is that sort
Yeah.
of, like, primal brain, right, that has an
Right.
automated response, right? In your example, and a good psychology example that's used all the time is a bear, right? So,
Right.
I get attacked by a bear, I'm gonna have a reaction if I see something brown and fuzzy, and that may not necessarily be because I've logically sorted
Right.
out that prefrontal cortex and all that sort of as you're referring to, like, this energy sort of willful, right, experience. I'm just gonna react, and that is to our
Right.
benefit. Point that one time that it's a bear, we better go. But also, if I have panic attacks every time I'm around something brown and fuzzy and I work at the brown fuzzy fleece store, it's
Mhm.
now become maladaptive, right? It's actually now getting in the way of
Yeah.
me doing things. So I have to sort of note that automated process and I have to put some of that thinking, some of that higher levels, more sophisticated brain region in that front there thinking, hey, you know, this isn't gonna hurt me. This is okay. And there's lots of different ways to do that, right? And the more I touch the fuzzy fleece and everything's okay, yeah, that's exposure therapy. I'd probably feel a lot better actually working at the fuzzy brown fleece store. But yeah, I think it's a great point, and I think we take for granted that the way our body feels and reacts to things, we sort of push that to the side. And I think it is so. I don't think we know it is so related to our brain and our bodies and our mind and gut health and how interconnected those things are, which was my segue into gut health, uh, which is what we do. Yeah.
Right. Exactly. So gut health, and there is recently gut brain axis, right?
Mhm.
And gut brain axis, and I was reading a lot, and I should ask you this question, right? I was reading a study somewhere about depression.
Mhm.
There is a huge correlation between IQ level and depression.
Mhm.
As, do you have anything to say about that? Positive correlation. The high IQ
Yeah.
people have
Yeah.
higher depression.
Yeah, give me a couple more years in the doctorate and I'll have a much better answer for you, I think. But the first thing that comes to me is ignorance is bliss, right? I
Yep.
do think that there's and obviously, whenever we're talking about different mood things, we're talking about neurobiology, right? And so there's always going to be a bunch of different factors in nature, nurture, which we now know is kind of the same thing with epigenetics, which I think is fascinating. Our nature is, or our nurture rather, is literally impacting our nature. They are bidirectional, they are live, they are dynamic, they're interactive. They're not these two separate things. And it's a some of this and some of that. It actually they're kind of dancing together to make who we are. So yeah, I mean it's a very interesting point. It also I think there's some other demographic, I think men, don't want to throw out any false information in there. But yeah, it is interesting to consider when we see trends and data, what's causing these, right? And what
Right.
especially when it's a big topic like depression and it's so multifactorial, it does sort of it's a really interesting uh jumping off point. One thing I'm really interested in is actually the gut microbiome and that being a mediator
Yep.
between mood and lifestyle, right? Like, and that again is sort of we know they're interactive, we know they impact one another. Can't say this one causes this one or this one causes this one. We think they're doing that dance, but what's the music? What's the tempo? What is the dance? And maybe probably gut health has something to do with it, which I find really interesting.
Me me too. I think probably you are a clinician, so you have to be very cautious about saying things, but I am not. I can be more I can have more freedom. So, and yeah, I can use more colorful language. But again, at the same time, based on the research and education that I have done it personally. So my thought on IQ and depression is, and again, it comes from my personal experience. I'm not saying I have a high IQ. What I'm saying is I used to think a lot.
Mhm,
So when something happens, right, when you think a lot, our brain is again wired towards negative bias. We think more negatively, and then we go to a spiral.
mhm,
So again, thinking a lot and high IQ is very correlated. Whereas you will not see unhappy dumb people.
mhm,
The reason why is they're not thinking. It's like,
mhm.
okay, it's not, I'm not trying to disparaging about dumb people or the people who don't think a lot, but they're
Mhm,
just happy. You can find, we can find our friend circle also, right? When something happens, you're talking about this election cycle as well. Somebody won, somebody lost, irrespective of which party it is. If you are on the losing side, you're thinking too much about who won, and you have a very neurotic response to that because you're thinking a lot. Whereas we can find among our friends and family just going by, they are not just thinking about what were the consequences of it, what went in it, what the policy went in it. All right, it went in what maybe that's ignorance. You talk about earlier, ignorance is bliss. That's
mhm.
in a way they're smart, but the smart people are not smart. They're just trying to cut it too much and get that neurotic responses and get get sad more and so on. So I think what I'm trying to say is when you think a lot, and high IQ people have to tend to think a lot, and we tend to think more about the negative consequences of it. Perhaps that perhaps it cause some depression, mood disorders, and anxiety, and so on.
Yeah. I mean, I think there's again, probably I do have a tendency to if I don't have a good recent meta-analysis, it is really hard for me to
Right.
be nailed down on
Right.
something. But I think there is plenty of data available to say that the emergence of the amount and availability and access to information
Right.
is not something that our brains typically do super well with, right? They kind of are meant to we talk about this idea of simplicity. And I think there's a lot of it, what is that if not meditation, right? What is that if not trying to center and find peace and sort of, not get the overwhelm of the data. And if we think of our brains as these data processing machines,
Right.
we've they're now overworked, right? There's just so much that's available. There's so much to pick apart. There's so much to go down. There's so much sort of grist for the mill, if you will, right? That I definitely think in terms of, you know, thinking or overthinking or whatever else, there's just people are being bombarded. And we do see that trend with the rise of certain things, right? We have access to everything at all times, which is great. And it also is hard. We're not really we have to figure out how to adapt to that.
Right. That adapt. And this is my there is another reason why we started Guts Fair is
Mm,
this, which is something by design and by organic.
mhm,
I'll give you an example, right? The more we are getting into the future, the more people will get sick. The not because we don't have access to medical care, we don't have access to food, or we don't have access to nutrition and so on. It will be because we will be deviating away from our evolutionary past. Consider that our gene, and it's designed to work in some other way. As we deviate our evolutionary few things, to eat the at a when we are thirsty, to sleep when we have to sleep, right? All of these things are changing, and the rate of this change, because of technology, because of abundance, is only deviating away from it. So
Mhm.
when there was not abundance, when there was no technology, when there was no industrialization, right? People woke up when there was sun was done. People ate when they're hungry. People got nature and so on. So organically, even without thinking,
Mhm.
they are attuned to the natural cycles of it. The,
Mhm.
the body as a machine is working where it was designed to work, right?
Mhm.
Now, fast forward now in the future, people will have to be insanely, say, architect their own, architect on their health and daily lives, which aligns with our evolutionary past.
Mhm.
One small example here is working from office versus working from home.
Mhm.
So when you work from office, there's a natural rhythm to your day, right? You wake up at certain time, you go to office at certain time because of external accountability. Let's put it like that. External accountability. Uh, Whereas when you work from home, you don't have all of those external accountability, which makes you organically be sequence your natural rhythm.
Mhm.
M- Instead, we have to be extra disciplined, and you have to be extra disciplined. You have to be self-motivated in order to design your daily life. So
Mhm.
am I saying it's not possible to design it for the best productivity working from home? It
Mhm.
is possible, but one has to put on the extra effort to do that. Similarly, because of our technology abundance and so on, we'll have to put on extra effort. Another
Mhm.
example is we talk about social network all the time, right? Social network all the time, we consume a lot of information all the time, and most likely the way the algorithms are designed, they're designed for momentum and engagement. They'll feed you the more of the same, and something like that, right? So
Mhm.
so then previously when there wasn't that algorithm, something like that. There is external triggers that feed us variety of information, right?
Mhm.
And also the volume and the velocity of same type of information was very less.
Mhm.
Now the variety, and also the variety is less.
Mhm.
Previously variety is more, the volume is less, and the velocity is less, so we're able to think through more critically. Now we have to be very objective, very critical about looking for it. Hey, be aware in our mind that, am I only getting the information that I am seeing? What's
Mhm.
the alternative point of view?
Mhm.
And we have to be very self-disciplined, proactive about that.
Mhm.
That variety was organic before. Now to get that variety, you have to be proactive and
Mhm.
similar to others. So that's my outlook about why to start God's fair. Then we need to start giving tools to people so that people can be proactive. If there are no tools to be proactive, then the health will be even worse than that. So yeah,
Mhm.
that's why, like, and even s- talking about bigger picture or talking about more philosophy about why, I think that's another reason why we're starting God's fair.
Mhm. I my on the not flip side, in the same sort of
Yeah.
vein of little departure is there's so much information. It is so hard. Most of my patients, when they come in, they say, "Hi, I've read 75 different things about this. None of them, they all disagree with each other. I don't know," right? Like there's the sorting and the vetting process of data is extraordinarily difficult and at some point prohibitive, right? And to your point, if you're just getting, if my algorithm knows that I love, diet trends and it picks up that I'm constipated, it's going to start throwing me right? Like some other it's gonna feed me maybe not what's most valid or most credible. It's going to give me what is most clickable or what is
Right,
most interesting to my own perspective, right? And that becomes
right,
really dangerous for my patients that right? That's not, and even if they did have an objective, large data set to comb through, while that may quite literally be our profession, it is not theirs. They still have to go lead these very full lives, and they're still trying to gather these little bits and pieces from places. And the idea of having a centralized, validated tool that they can go to reliably. To me, it also they're not having to weed out all the nonsense, and sometimes the nonsense doesn't get weeded out. And a lot of what I'm doing is taking misinformation and sorting it away from good information with people,
right.
right? Because there's really not a good way to do that other than talking to a professional or talking, and even then, you might get some disagreement between folks. So I really love how we talk about simplicity. We talk about how that can feel calming and that is maybe a better way for us to work. And that's I love the platform because of that, right? Like you're selecting a color, you're talking, you're having this experience that is not requiring more decisions, not requiring, all of
Yep,
this. You don't need to become a researcher.
right,
um, Nor should you try if that's not what you do, right? That is a skill set that's honed over years, really decades, right? And
right,
that's so unfair to expect people to do that, to be able to achieve good health outcomes. That's not
right.
what medicine and healthcare should be. It should be supportive and it should be foundational, and all the brilliant work they do in the world, we're benefiting from that, right?
Yep.
So
And also, definitely, I think and also I look at from another angle called like skin in the game. Who has in short-term and long-term incentives? Right.
mhm,
For example, as a patient, I have the short-term and long-term incentive to be healthier.
mhm,
However, when I also meet, let's say, people, even we especially talk about the incentive in this structure about short-term and long-term. Let's say I go and meet a doctor and let's say I talk about my colonoscopy, right?
mhm,
So colonoscopy, s- maybe it's not necessary to be the patient one.
mhm,
Therefore, that's another fundamental thing is the previously it isn't used to be so, and then it isn't used to be so that doctor also have the skin in the game, meaning they live in the same society, there are family relationship, there is ethical relationship, they were the doctors with the best for the patient. Now, because of the another class that coming in, the administrative class, who have no skin in the game whatsoever, meaning
mhm,
whether the patient or clinicians do good job or bad job, they only defined by the short-term incentive structure they can maximize. Therefore, even in that and this particular, I look at from the incentive lens as well. So who has the most incentive and skin in the game lens, and patient has the most. And the patient themselves have to be the pilot and have to make the decisions for themselves, right?
mhm,
Our job is not to take decision on their behalf. Our job is to I provide the education, provide the tools so that they can make those decisions for them. Here, I'm not saying that they need to be the researchers. I'm not saying that they need to be the doctors and so much, but some spend time, sometime, or be aware of that. And just because somebody said so, you don't have to take it on a face value. You can self experiment you experiment yourself and see what works for you, what doesn't work for you. And especially in the again, I can say this because I'm looking from the patient's perspective, and I have a deep respect for clinicians as well. And I keep on saying they are the victims of the incentive structure designed by the administrative class, right?
mhm.
The administrative class. Say that I have huge empathy for them. Uh, what I'm saying is for the patients, if you're taking many decisions about this distance, the incentives has to align, and our
Mhm.
job is to give them the give them the all the information available, all the tools that available, so that they can truly pilot their own health, right? So that's what where we're coming from.
Yeah, and I think there's more as a clinician and knowing what the technology can do in gut sphere, better accuracy, more
Yep.
specificity around symptoms, better diagnostics, and that I think that's an empowering tool for clinicians too, right?
Right.
And do my job better if
Hmm.
someone shows up with
Yep.
all of their food and symptom, right? Because I'm not
Correct.
spending a month, month and a half of trying to get that data through less sophisticated means, right? I'm
Right.
relying on memory and all of that stuff, right? So I think it's in a in a space I agree in a system that is not super designed necessarily for outcome, long-term outcome
Yep.
in that system that is not willfully going towards there. And I think it is, if we want to be optimistic, right? I think most of the GIs I work with really want their patients to feel better. They really have, I have a GI that
Right.
I've worked with for a while, and her father passed away from colorectal cancer, and she carries it with her and she tells her patients, and she is really, a watchdog for these people. But I think about her and I think about how she has to see her wait list is a mile long to get her time is like, being gifted something. And so to optimize that time with her, like what a wonderful gift. And for them too,
Correct.
they're we're not utilizing clinicians' capacity correctly, right? We're doing a lot of that administration that doesn't really need any training, or, brain power
Yep.
to do. I mean, it does in the way that it gets guided, but that's what's baked in to the
Yep.
technology that
Yep.
it's emulating that, right? But yeah, I think from the clinician side, it's an empowering tool to be able to treat people more
100%.
effectively and to not miss diagnoses and to not overtreat, right? So to get
Yep.
that sort nice combo the clinicians are looking for of, not putting people through the ringer every time just because, but also not having enough time to really fully examine and understand them and therefore missing things that could
Yep.
be very costly.
100%.
Mhm.
I think another lens to look at is from like how to make it accessible. You know,
Mhm.
the, another thing is severity, right? As a patient, there is a certain degree of severity. And
Mhm.
after a certain degree of severity threshold, I go and see the doctor.
Mhm.
If there is something occasional for my own thing, when I had occasional constipation, so I was aware of that, and I could do something at that particular time, then it couldn't have been severe to chronic constipation one. And as a patient, I would avoid, okay, it's not the life-threatening one. It's not fatal. It's not like it's not impacting that. And you try to ignore it, procrastinate, and going to doctor. And especially doctor is super expensive.
Mhm.
Super less severe and
Mhm.
stop the severity escalation.
Mhm.
That way, right? I'll even won't have to visit doctor when I can self care myself. I'm not
Mhm.
saying treating or diagnosing when it's more severe. Obviously, when there is severity, there are a lot of other factors that coming in. So, how do we empower people so that people can be tuned to their level of severity, and
Mhm.
based on their level of severity, they can do self care or they can do a talk to find the right clinician. And when they come to the right clinician, they can present their data so that the in that particular span of time, as you know, there is in the US, right? There is only 8 minutes you can spend a time with a doctor because other time doctors are very. So how do you maximize that particular time? And all the same thing also that there the supply of clinicians are so less, whereas the rise the rise in the patients are high so high. Our job is to stop at the
Mhm.
lesser symptoms and not make a chronic one. Can we do that? And when you go to a clinician, present the data and say, as you said, right, okay, helping clinician to diagnose, because one thing we know that is one thing which is maybe we can agree on this. One thing is unreliable is our memory. Our memory
Mhm.
have so much recency bias, so much
Yeah.
recency bias. Simple question: have you
Lots of
been drinking? Yeah, have you been drinking water? Let's say 3 liters of water per day. And the doctor asked me that if I have been drinking for the last 3 days, then I will say yes. And yes. Whereas there is a data like for the last 30 days. Hey, it's only 3 days. You have been drinking for the last 20. 27 days you're barely drinking any water, right? As simple as, I'm just making things up here. But again,
But mhm.
but 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 the objective data is more accurate, but the recency one, the people have recency bias. That's we can argue that it's 100% true.
And they have the way we code our memories is our memory, right? So
Yep.
if we feel like we've been doing well with something, we'll
Yep.
say we've been doing well with it. And that to your point, there's really no objectivity there. I've
Yep.
I've had plenty of patients who say, "Oh yeah, no, I haven't had any of my triggers. I don't know, it's so weird. My stomach gets off." I'm like, "Oh, really? Okay. Well, I'm like, okay, well, let's dig in. Let's see. Maybe something's hidden in there." Right. And more times than I can count, we start to do a recall, a dietary recall. We use it a lot. So it's looking at the last 24 hours, try and capitalize on some of that recency, right? And walk through. And as they were going through, like, oh, I guess oh, you know what I did? Oh, and as they're saying it out loud in that setting and they're trying to recall it, it gets framed in a different light. And
Right.
wait, on the severity thing, I think that's more subjectivity, right? And we know that pain in general is highly subjective. We know that folks with IBS have part of what characterizes it is visceral hypersensitivity, right? So they're going to feel things a little bit more. So I think there's a lot of different factors that play into that. And having tried some first line things, some over the counter, first line, easy peasy, right? If it was hydration and movement, if hydration and movement is going to manage your constipation really well, the GI is thrilled. And, you
Yep.
know, I think you should always have an established if you struggle with GI issues, you should have established care just because if something does arise, it just makes it easier. All those barriers to care that you talked about before, a lot of those are gone, right? But not wasting your time and your money and everything else to go have them say, try these first line things. I think you're all right. And then they work and all of that, right? Or they don't work and you can go in that appointment and say, I've tried this, I've tried this, I've tried this. None of it works. Right. And that puts the clinician in a different spot where again, they are sort of empowered to do that deeper
Correct.
work of any good clinician is going to try the easiest thing first. Right. Like that should be a rule of thumb. Right. Like we don't want it to be the super complicated, rare, hard thing. Right. And most of the time it's not because it's rare. Right. So I think that's a really great point in terms of the severity and in terms of getting people some data that's, again, also not just coming from Reddit, right? And you just find a random thread and that's what you're going to go by because it might be, it gets dangerous, right? I've had people that just, oh, more and more and more and more fiber because I read fiber is great for constipation. And with no context, no follow up, and no monitoring and no tracking, they're basically getting impacted, right? Because it's a transit motility issue that may be organically something else, right? And you're just adding all of that volume and mass when you can't evacuate. So, I think there's a time and a place in having something to do that screening process and to capture that data well is great. It's a game changer.
100%. I think that's what we want to do. And also being able to do the multivariable analysis about presenting that information or
So
capturing, like capturing, okay, there's a symptom, capturing this nutrition, capturing other activities they do, environmental factors. There are so many variables. And I did that because I'm really glad that I'm a nerd because when I started doing okay. And I studied industrial engineering, and my mindset is like, okay, everything is a machine. There is an input, there is processing, and an output. Oh, chronic constipation, I'm finding it really hard to defecate. And when I did defecate, there is hemorrhoids and fissure filling up. Okay, that's the output part. So where do I need to start from the input part. Okay, this is input part. I need to start from the environmental part, right? And then I go to processing part. Processing means digestion. So how do I improve my digestion? How do I improve my processing motility? How do I improve my motility, right? How do I do that? And then start working around and eliminating all of the factors. Sometimes it's just not one factor, but it's a combination of factor. An analogy that I give is, and some people say this, hey, I was absolutely fine doing that, but at a certain point in time, the symptoms started showing up. And
mhm,
the analogy I give is, let's say, if you're there's a cliff and you're closer to the cliff, right? If you're further away from the cliff, you have to put a lot of effort. And when you come to the near to fall off, but if you're close to the cliff, somebody just pushes you like this, right? Then you fall off the cliff. I think the symptom of the same thing happened, right? When you are the symptoms of the same thing. When you're doing multiple things, you're doing the same thing, like you're further away from the cliff, but you have multiple factors coming in, it pushes you closer to the cliff. And after a certain time, even the small thing that you do is boop, you just
Mhm.
fall off, right? So doing the multi-factor analysis and so on, it's quite. I really I shouldn't say this. Looking back, like now, I can say I enjoyed this, but when I was suffering through, it was such a painful process. Oh, but now looking back, okay, it was fun to do that as well. Now, I think it's a good time to segue into one more thing, which talk about, you know, digestion, right?
Mhm.
So, especially when people get really confused, I get really confused about it as well. That I start eating something, how the digestion works, number one.
Mhm.
Number two is so there is some kind of symptom flare up after
Mhm.
meal, right? Meal, and the timing could be different. That's second. And third is the location of the pain, right? And
Mhm.
there are a lot of GI issues, and one can conflate about it. And this is for the self-care side of it. Obviously, the symptom is severe, and like you said, the severity is subjective.
Mhm.
But for some people to understand, okay, based on the number one, how digestion works. Number two, based on the symptom after the meal timing, what could be the potential GI issues, what could be symptoms, and what could be done at home to alleviate some of the symptoms, and
Mhm.
also the where could the pain locations, and making we can unpack all of these things so that our audience who suffer from a lot of GI issues can get framework to think around what could be causing those symptoms.
My deeply unsatisfying answer, and I do have satisfying
Yeah.
answers, but my my overarching deeply unsatisfying answer is it so depends, and I see gut sphere as a way to collect this data and speak to a clinician about this if
Yep.
there's all of those factors, right? Like how to sort of figure that out. So that's my unsatisfying answer is that it really, really depends. But generally, like things that we think about in terms of timing and digestion, digestion is fascinating, super cool. It's very interesting. I found an article I sent that we can maybe
Yep.
post in the show notes from Healthline. Healthline is a good resource, I think, anyways, because it's
Mhm.
very digestible. Of a pun, but it also is pretty comprehensive. It does a really nice job of collecting available data and then synthesizing it in a way that feels complete, but also you're not going to spend 10,000 hours reading about something. So it's a great resource in general, specifically around different nutrition things. And they'll give you sort of a broad idea of different times as we go through the segments of the GI tract. But I think what's important to remember is sometimes the problems are stemming from transit time in those regions themselves, right? And the other thing I want to caution against is let's say you read to eat blue Smurfs and then track it through your bowel towards the end. That's going to tell you whole gut transit time. That's going to tell you from tip to tail what your transit time is. That's not specific enough necessarily. You can have different dysmotilities in different segments of your GI tract, and that's going to be really important to your diagnosis, right? I
Mhm.
could have perfectly fine small and large bowel motility with gastroparesis, right? With my stomach not moving to squish food and get it out into that small intestine. I could have delay even in my esophagus. It could not be that peristaltic movement could be delayed
Mhm.
there. That's a different thing too. So I think one thing I want to throw out there is that it's highly, highly individual from person to person, but it's also there's even variance from segment to segment, how we process food and what the delay might be. So I think sometimes there's this overarching idea that
Yep.
like I'm slow or I'm quick and you could be slow in a region and not in another. And that can also be maybe your symptoms are SIBO symptoms. Okay, chicken or the egg, dysmotility, either way, causes SIBO. It's a big
Right.
It doesn't necessarily one to one, but it's a big risk factor for it, right? So I think that's the other piece of it when considering motility is that sometimes the motility itself is the issue and the symptoms you're experiencing are a secondary sort of symptom or set of
Hmm.
symptoms from the initial motility. What we eat can absolutely, the way we move, how we eat lifestyle, right? So not just from person to person, but from meal to meal. So that's why I always think it's just strange to talk about like, sure, gastric emptying time, 3 to 4 hours, right? Like that's what we think of. But what did you eat, right? That's not what
Right.
2 bites of apple is going to take. And it's also probably not what, chicken parm the size of my head is gonna take, right? So there's variance in what we eat too, and we don't typically some people do. They love the structure, they love the consistency. Some people eat breakfast, lunch, dinner, and it's the great. A lot of us are just we're it's a little bit more varied than that. So that's absolutely gonna make a difference as well. Timing of symptoms matters in that if it is food related, and it can also be a cue that maybe it's not food related, and I'll explain how. But if it is food related, where are we accessing the different parts of the GI tract at what times and what could be happening there, right? So if someone comes and tells me I take 2 bites of food, I start eating, I'm so hungry, and then I feel so incredibly full, that's early satiety, right?
Hmm.
I'm curious what's going on in their stomach, right? If someone tells me, oh, and this is to your point where it gets really complicated. It's a little bit like used to work in public health and we were housed with epidemiology, right? Really hard if you haven't noticed to trace foodborne illness outbreaks, right? Because it's really hard to say. You need to get enough people getting sick at the same kind of time points, right? Like if listeria, for example, we just had that awful big recall of a bunch of things. Listeriosis can take effects a day to 30 day, right? Like there's a really broad range in the way that that can impact us. And we're getting that here too in terms of timeline that there is a really broad range. So if I feel really sick at lunch, and if a patient tells me I felt really sick at lunch, I don't just want to know what they had for lunch. I want to know what they had for breakfast as well, right? Because what's going on? Is it that, food from earlier is acting in your small intestine or in your colon, or is it the immediacy of something hitting your stomach, right? And maybe the beginnings of going into the small bowel. So that is it's a very tangled web though, which is why collecting data and like a food journal, a food and symptom journal, I do this all the time. A lot of times we need that data as GI dietitians, right? Like we want to see everything sort of match up and get that data down so that we can start picking those out. Because to your point too, with the cliff metaphor that I really like, the way I describe it to people is you have triggers of varying degrees, right? So maybe you have a +1, something else is a +2. And at a 7, you're going to feel terrible, right? But what were the ones and the twos and the fives? Sevens are more straightforward. So that can give us a little bit of insight into what's going on. Big patterns like I wake up every single day and feel fine and I feel terrible every night. Well, do you eat the same thing every day? No. Okay. So I'm leaning towards that doesn't rule out the actual food that you're eating, but that does tell me, okay, do you feel better after you poop? Right? Because what are
Hmm.
we doing? We're accruing food. We're accruing volume throughout the day, right? So we get little hints at timing like that too in a bigger sense. Yeah.
Got it. Think so. Let me share my bit of own experience, right? So when I start eating
Mhm.
and then s- after 30, 40 minutes, if I start getting pain around the stomach, right? So
Mhm.
what could that possibly mean?
Yeah. It could mean a bunch of different things. I'm certainly not thinking your colon
Yep,
at that long,
exactly.
right? So when we think about like an intolerance of something that's really being picked apart in your colon, I'm not thinking like fructose intolerance. It has to get to the bowel intact to start wreaking havoc on the body, right? So we do start thinking about those sorts of things immediately. And this is me
Hmm.
just giving you my sort of clinical one too. I would think, okay, well, it's in your stomach. Is there some GERD going on, right?
Hmm.
What is really going on in your stomach at that point? But it could
Hmm.
be trapped gas. You could have swallowed a bunch of air while you were eating, right? But location wise, it tells us, okay, we're dealing with the earlier parts of the GI tract,
Correct.
right? So
Yeah.
it's narrowing the location of, well, what could be going on in those different places. Then I would typically ask, well, what was the food? Right? Very different if you tell me my stomach hurts after I took 3 shots of tequila and drank a cup of hot sauce. I'd say, "Huh? Your stomach does hurt." Yes, that makes total sense. Versus if you told me you had a little bit of oatmeal, right? Like that would be those are 2 very different statements with 2 very different takeaways around what might be happening in
Mhm.
terms of the probability of, is it food? Is it like what's really going on? But it gives us a place to start, and it gives us that
Right.
time. And getting to me any one instance is, I don't want to say negligible. I don't I don't really, and I don't want to say that I don't care about it. I wanna know, what is every does this happen every day at
Right.
the same time? And that's where I think that data collection piece is
God.
so extremely important so that
Hmm.
we can start picking out, you
Yep.
know what? Time of day is not that important. It's really following this ingredient, and let me go and see if that tracks. Or, wow, it doesn't matter what you eat. You wake up every morning feeling like you have to vomit. Well, that's acid. That's acid in your stomach. That's GERD, right?
Hmm.
Potentially. So those are things to sort of consider, but that bigger data, if someone wakes up one
Right.
morning and feels terrible, okay. If they're waking up every morning, I say, and this is where, to your point, some of those little interventions, try eating something small and digestible first thing. Does it help? Oh my gosh, it helps so much.
Hmm.
We've
Right.
tested the hypothesis that acid didn't feel good in your stomach and that maybe that was part of it. And then we didn't prove the hypothesis right necessarily, but we certainly have done a bit of, we can file that away as a new data
Right.
point. Yeah, that was what helped.
Yeah. As you're speaking, the engineer in me starting to try write an algorithm. Right? So in some sense, so algorithm is okay. I start eating. If there is immediate pain in my esophagus area, does that mean something?
Mm,
Then after it reaches the stomach, right? I stomach based on the, let's say, small or big, how big meal, based on like whether I eat this simple carbs or based on I eat little oily big fatty meal, like
mhm,
I have a pain in my stomach. Then after like hour or so, I start getting a pain around the upper abdomen. Then if I start getting pain on the right side of my abdomen, lower side, left side of abdomen, lower abdomen, right? Then I have on the rectal area and so on, right? Is there a kind of some kind of a mapping that I could get a general sense what could be the causing, what could the issue? Because you also mentioned about the motility, right? For example, let's we don't have to be extra accurate. We're like, okay, from this variance of the meal size, meal size from small to big, it for generally from the variance is it takes, let's say, 2 to 4 hours in the stomach, then it takes about like, let's small intestine about like 2 to 3 hours of time, then the large intestine it takes this amount of time, right? And then I start mapping that with the timing of the symptom, then say, okay, there's something, the general idea about it. I'm not for diagnosis perspective, but for my own perspective. Okay, this could be the reasons why I can doing it, and then I can start being more narrow down my data collection part of things, right? So this is engineer in me asking for that. Okay, mapping out an algorithm for a thing.
mhm. And the non-committal clinician in me is that it's a 3D model with more inputs,
Right.
right? Like
Right.
we would need to overlay
Hmm.
someone, you know, individual day digestion, even from day to day, right? Like
Yep.
I had someone, they were just, I forget what the conversation was. It wasn't a client, but they were like, yeah, I started walking and a side effect, like they were walking for mental health. And they were like, a side effect is I've never been more regular in my entire life. Like I used to go all this time. So even from, even from little changes to your day, right? You're sick
Yep.
in bed for 3 days, your motility might change, right? So there is, I think location is always going to tell you what is being acted on, right? So
Yeah.
location is always important, even independent of timing. Timing is the
Okay.
thing that you can sort of pair with digestion if we think there may or may not be a food relevance there, right? Because we look at that region, we say, well, what could be going on in that region? Well, what does the GI tract do? It digests food, right? So
Right.
going through that big long tube, or is it something else, right? If someone was eating in 20 minutes after they felt, intense pressure lower, say, okay, well, we triggered peristalsis. That's still the colon, right? We got that movement from eating. Maybe there's something going on down there. Maybe they're constipated. Maybe there's
Yep.
some, again, I'm not a GI, so that would be that their place to diagnose those things, but it would tell me, okay, well, what's being acted on? It wasn't the food
Right.
that they eat necessarily, right?
Correct.
Because
Right.
the
Right.
food is
Yep.
there at that time. So it's helpful as you're saying, and from like a mapping perspective, to have a general guideline around because and that is a huge misconception. I know it seems very straightforward as we're talking about it, but we are really not primed that way. When we feel something in full circle to our earlier point, when we feel something horrible, we're going to pair it with what just happened, usually, right? So I have a lot of people that come in and say, I'm allergic to, who's what's it? And I'm like, why? And they're like, oh, because I have this, pain. And okay, well, maybe, totally, maybe, right? But I think getting that more specificity of, well, food isn't acting at that point, at that time. What else could it be? Right. So that can be really, really helpful.
Great. So, irrespective of meal timing, you say that location is important, right? Location. So, location can tell you, okay, this could be GI. For a few things that I know, then you can add things on. For example, if I have a pain in the stomach area, that could be GERD. Then I have a, let's say, acid reflux, so that sour comfort just coming out in the morning, that could be GERD. And also, about the GERD thing, uh, during the night when you lie down and you start getting in a more acid reflux, that could be good as well, because when you horizontally versus vertical, when you use a vertical, it doesn't come up to the mouth, it doesn't come to the esophagus, but when you're lying horizontally, it comes across. So you can say that because of that location, it could be potential, there could be another issues, but GERD as well.
Mhm,
That's the second thing. Also, about what I have heard is also people have gastritis. They don't eat in the same time. If they have to go fasting, or if there is a timing and the thing, timing is just misplaced, then start getting some kind of pain around the stomach area. Then you just go, okay, this could be because of gastritis or something like that, right? So again, and then people have the upper abdomen. They start about, okay, also burping too much,
mhm,
burping too much, and that could be like kind of a SIBO related, something like that. So this is, based on my experience. And then if you go to right side of abdomen, left side of abdomen, irrespective of meal timing, could you walk me through that particular mapping for general sense? I'm not saying this is for diagnosis, clinical diagnosis. For
mhm.
clinical diagnosis, obviously, whoever are listening and watching us, please consult your doctor. But
Okay.
here, I think we're saying from the education perspective that, okay, and one is education perspective, another part is also about action perspective, being aware and collecting data, so that when you go and meet a clinician, you can present, hey, this is what has happening throughout me, this is where the pain. And also, another thing is have the vocabulary to explain. you know uh,
Mm,
for most patients, they also lack the vocabulary to explain to the
mhm,
clinicians what's going on. That's the reason why I'm asking that, okay, we map that thing, we can provide the vocabulary to the patients, and then explain it to clinicians, or if even Google, right? Having the right vocabulary, Google also helps.
mhm. And the Healthline article, again, don't Google. Don't Google. But that's a really good jumping off part of point of here are the ranges of the timing. Here is literally how food starts in our mouth. We start digesting with amylase. We start breaking down carbohydrate in our mouth with our saliva. We push that food through down to our esophagus. It gets into our stomach, right? It has all of that timing, the way that it sort of goes through. The and I think
Can you
difficulty.
can you summarize for our audience,
The
like, the process about, like, how, like, what's the digestion process, how long does it take, and also based on the location, like, can you just briefly summarize so that obviously we'll link to the healthline as well, or it will be helpful to, get the summary about that as well.
Yeah, and again, there's I know, I'm so annoying, but there's so much variability, so
Right.
I'm not gonna commit to timing because I don't
Okay.
want to be misleading, and if someone is curious about that, they probably have symptoms, and those symptoms there's a decent chance there might be dysmotility in play, right? So
Yep.
we also in terms of like a selection bias, this is not maybe the dead center 50% of that bell curve of
Right.
right? But generally, we're eating that's our first and I'll highlight some things about digestion and things that could be going on, but as you go through, all that does as a dietitian is how might food be implicated in whatever differential is being created. So it's opening the door to,
Mhm.
oh, here are 10 things, which ones have to do with food, right? And then this is also where we can take data to the GI and say, hey, here's this here's this list of
Right.
things or right. And that's their job. Their job is to take all that
Right.
information and to make that list and then to start ruling stuff out or ruling stuff in, right? So,
Right.
but we start digestion in our mouth. And I do want to emphasize that because I think that we can eat really, really fast and we can eat slow. And that actually does matter in terms of digestion, we do start breaking down carbohydrate in our mouth. I also think as just a mindfulness practice, you might want to try, right? Like we're eating on the go. Food can be very utilitarian sometimes, but this is where mindfulness can be really helpful in preventing a lot of air swallowing, which can create gas. It can help start the digestion process and do that more effectively. Your stomach is going to have to mash stuff around and break it down with all those juices where it goes into the small intestine and there's more juices to break stuff down for absorption. If you can give them a head start by chewing really well, that's awesome, right? So chew, 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 as I say to my toddlers so they don't choke. You may have this, but chew, 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 chew. That's for a reason. But and then as it starts to go down, there's a couple of different things that could affect the esophagus. One thing from a dietary management perspective that we often think about is, GERD, any sort of like inflammation or anywhere where it's difficulty to swallow, there's difficulty swallowing. That's something that we would want evaluation around, right? For many reasons, but that can be a reaction to food. It also can be a reaction to just having acids filled up there all the time, or it could actually be something physiologic that, we really need to sort out with GI. So that sort of goes on the esophagus, goes into your stomach. Between the esophagus and the stomach, there's something called the lower esophageal sphincter, and it's basically just like a little gate. It's a little gate between your esophagus and your stomach. And its job is to keep the stomach stuff, because the stomach has to be acidic. That's part of its job to not splash back up that esophagus. It's a normal tissue that doesn't want all that acid on it, right? There are different things that can compromise the integrity of that wall, one of which being pregnancy. We always hear about women getting heartburn, and we have this sort of image of women with a thing in Tums. Everything relaxes in pregnancy so that we can deliver babies, and it's non-specific, and that can happen to that lower esophageal sphincter as well. It can also happen with aging. So the integrity of that's really going to determine some of the factors there. To your point, it is very mechanical in nature, right? So the fuller your stomach is, if you lie down, there's more potential for that to splash back up, right? So mechanical interventions to prevent some of that can also be really helpful. Now we're in the stomach. You mentioned gastritis. I think it's really important to note that, and my GI supervisor says this all the time, and it is now, stamped, trademarked in my head as this, but an empty stomach is an acid stomach. I think that's really important to remember. Your body wants to be digesting food. Your GI tract's whole job is to take food in. And while we need bowel rest, which we get overnight, it really wants to be working. It really wants to be moving. It wants things to be working through it, right? So when there's nothing there, that acid is just a free for all. Additionally, low acid, if you don't have enough stomach acid, that can create SIBO, right? Because we're not having the super acidic environment that's meant to keep us safe from and break down food. But then bacteria can move and go to places it's not supposed to be, which is true moving upwards too on different pieces of our anatomy. But we're in the stomach, that should go to the small bowel, small intestine, goes to large intestine, colon, and then we evacuate, right? In terms of nutrient digestion and absorption, a lot of that's taking place in the small intestine. The large intestine, we're getting a lot of electrolyte and water back. And I think
Hmm.
the important thing to remember about that in terms of transit time: hydration, 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 hydration. Because if your body needs water, it's going to recruit it from there. There is also not a ton of data that just drinking a ton of water is going to solve your constipation. But if part of the problem was you're creating these dry, hard stools because it's sitting too long, then yeah, that is going to be really helpful, just because we've sort of fixed what the problem was rather than make a
Hmm.
solution utility, if that makes sense. How's that? And then and to mention other digestive organs, we do have the liver and the gallbladder and the pancreas that are all doing their best to give us those, I talked about those juices that, help us digest things and break things down. We're being provided those from those areas too.
Cool. I think let's talk about like certain enzymes from pancreas, gallbladder, and liver, right? In the deficiency of those enzymes, what could be the potential symptoms and location of pain?
Yeah, so there's something called EPI, and that's pancreatic insufficiency. So basically, you're not making those enzymes in the same
Mm-hmm.
way. You're not maybe getting enough of one of them. That can be a really simple test at the doctor. Even like your PCP can run that if you're going to an annual and you're like,
Hmm.
hey, if your gallbladder is compromised, that's going to be fat. So when you think of the pancreas, you want to think of that. When you think of the liver and the gallbladder, you're thinking of fat, and getting the gallbladder is going to pump those bile salts in to sort of
Hmm.
break down the fats so that you can digest them better. That both of those instances, we would think about malabsorption. We would think about when things aren't getting digested properly,
Hmm.
we tend to think quick transit, right? And
Hmm.
flips both ways too. If you just happen to have really quick transit time, food's not sitting long enough for all of those processes to happen. So that would definitely be a place in nutrition where we worry about deficiency. If I have someone that has horrible, why is diarrhea such a big deal? You're losing electrolytes and fluid. Your body really needs those to function, right? So the quick constipation can be really, really tough. I think chronically it is one of the more uncomfortable things, honestly. I know people say it like, "Oh, constipation," but it can be torturous, truly, especially if you have IBS and all of that pressure and all of the innervated bowel. It just feels awful. But in terms of like I'm really nervous. I need a patient to be calling someone. Lots and lots of loss is very scary very quickly, right? So when we're thinking of transit time and we're thinking about how quickly things go through us, we really do want it to be the right time. It's not the longer the better, right? We need to get
Hmm.
things moving. We want waste products removed. We don't want it sitting too long because we're just taking all that extra water out and it's just becoming more difficult to pass. Also, don't want it to be too quick because we want to be able to absorb
Right.
things and we want to be able to get what we need from our food and our nutrition.
Yep. And that's a good framework. I actually think about what works. Again, we all talk about personalization, right? Every person is different. And that's where we don't want to be on the ideological spectrum about. Here we say, right, six frequent meals versus 1 meal a day, right? And you're like, whatever floats your boat, whatever works for you. I think you got to be scientist of your body. It's like if yeah, I've been eating 1 meal a day, doesn't mean everybody in the world should be eating 1 meal a day. And somebody is eating 6 meals a day, then it works for you, great. I think because for some people, actually, it's useful, right? As you said, some people may have lower gastric just producing at one point of time in the stomach, and they start eating large meal, oh my God,
Mhm.
that's going to be a huge problem. For them, maybe start by building small meal a day that can digestible, and then frequent small meal may work. For some people who have a large digestive and they have trained their body to produce that digestive at one particular point of time, and they just eat one meal a day, and rest of the time their body knows to rest it, works for them. So
Mhm.
eventually, it's about what works for you.
And which is a good note on generally
Correct.
eating is going to create motility too, right? So put that as a side note, footnote on motility and transit time. That's one way we can create that peristaltic movement,
Yep.
because we can't just say and again, thinking about the different parts of our brain and the way that voluntary versus involuntary and all those, different
Yep.
functions, I can't just say move bowels, right? Like I can't, it's not my skeletal muscle. I can't just say like I want to lift my arm, woo, right? If I want to move my bowels, I can't just say that, but I can do things that I know are going to impact it. I can indirectly have that happen. And so what are those triggers that do that, right? And fat can do that. Eating itself does that. So there's a big intersection of eating disorders in the GI world because if we get folks that for whatever reason, right, are severely under eating and all sorts of disordered eating patterns. Obviously, again, it's digestion. It's going to impact the way that we function, the way that we feel. But one of those is if we're not telling our bowel that there's food there and we should move, our bowel starts to not move. And so
Yep.
that's a good point too.
Cool. God. I think for bowel movement, I feel like I'm a self acclaimed expert because I've tried few things, and I want to share with a few things that would trigger a bowel movement. Earlier morning, I think drinking warm water in a squat position, that triggers for me, number one. And
Mhm.
if I don't do that, then I do some kind of squats, or even I hang in a pull-up bar, that
Yeah.
triggers as well. And another thing is uh, after meditation, it triggers.
Yeah.
Another thing is after breakfast, it triggers,
Hmm.
right? And
Hmm.
then and so I can correlate that if I have been sitting around for entire week. I'm not moving that much around versus let's say walking, exercising. My
Hmm.
regularity is so different. And
Yeah.
the third thing is I'm drinking water or not in versus. So these are the things like I have known to be true for my body. so so I've designed my entire morning schedule to about okay, can I get, and again timing also, right? What are the cues to get that? Cues for that. For me, like drinking water early in the morning, stretching, and those are cues to trigger for the bowel movement, doing at the same time. So
Mhm.
those are things that works for me. And
Mhm.
another thing which I also work with, you talk about fat. Fat was so when I had chronic constipation, right? To get it every morning, I would eat 2 tablespoons of sometimes ghee, which is clarified butter, sometimes olive oil, sometimes coconut oil. Just eat on an empty stomach, and that would also trigger the bowel movement, bowel movement not immediately, but that would actually work also as well. So
Yeah.
when you're talking about that thing, oh, these are things that I've tried and I've known to work for me.
Yeah, and they'll work for most people just to varying extents, right?
Yep.
And to your point, it is so individualized. It's what does my body respond to the most? But all of the things you said pretty much are kind of proven, right? Like these are things we
Right.
know stimulates. Those are those indirect things.
Hmm.
Movement, eating, first thing in the morning, we tend to get stronger peristaltic response. And then the squatting is really interesting because positionally, we're just working with or against gravity, right? And relaxation, getting the right coordination of muscles to push and to release is also really important. So that's a piece that's not it's peristalsis, it's not also, right? And
Yep.
some of those like deep breathing, the meditation, there's another piece too of having the right muscle movement coordination. We'll have people do, diaphragmatic breathing before, during it's kind of it's wild. You what you think is going on and then, oh wow, that why does that make such a difference? And I think traditionally we think of just like straining as,
Yep.
sort of like more severity towards actually having a bowel movement. It's really not. There's a lot more elegant ways that are not gonna create hemorrhoids, and they're actually really effective than
Yep.
just, forcing. And they're less caustic as well, right? Like, we're not creating so much pressure that we're getting hemorrhoids or, forcing things through and getting fissures and things like
Yeah.
that.
Right. S- I'm smiling because I was reading something on Reddit. Someone posted, I think there's a subreddit called constipation, something like that. I'm very active because I try to help there, comment there. And one guy posted was he's constipated, and for him, sexual fantasy and so post masturbation
Mhm.
triggers con- triggers bowel movement.
Yeah.
It was so funny.
Well, that might be, if he's especially the pelvic floor is very implicated in evacuation. And people tend to be, and there can be dyssynergia, right? Where we're just not sending the right signals and things are not communicating the right way to that muscle. And now I'm getting into pelvic floor PT therapy territory, which goes to pelvic floor PT. But we need that muscle. Sometimes people have it in constant sort of contraction, and some people have it in constant relaxation. And the truth is we need that coordination to actually create the bowel
Right.
movement. So I don't know this gentleman. I am not a GI nor am I a pelvic
Yep.
physical therapist. But if I were trying to, collect the breadcrumbs of what's
Yep.
happening, well, maybe that's, that sort of release that actually of his pelvic floor, right? That he gets a little bit of relief from holding. Because
Yep.
you'll see look at toddlers, it can be quite behavioral, right? It can be something that anxiety, that's not a
Correct.
factor. So, yeah.
Talk about that. That's what we talk about. God brain axis to circle back, right? Somebody is like very tensed, and that
Mhm,
whatever works for them to release from that mental stress, right? From meditation or breathing exercise, or for this
mhm.
gentleman, sexual fantasy, or, or whatever that works for them, right? Again, we are
Make
speculating
money.
here. We don't know about that whether in his case, but again, that would logically that would make make sense, and I think maybe that's a funny bit, right? People have different mechanisms to mechanisms, and whatever works for them, we're not judging whatever works for them. But this is quite quite hilarious and could be controversial as well.
I won't integrate it into,
You know,
the clinic anytime soon, but yeah, it's not a huge leap though either,
right,
right? Like,
exactly, right.
um, the different interventions and what they're doing. Yeah.
Right, right. And, exactly. Whatever works for you. I think it's, and again, I get very curious and excited when some people trying something which is sharing some out of, something out of the ordinary and say, okay, that works for him. Maybe that works for you. And like, who are we to get a judge people, right? If that works for them.
Absolutely.
Hey, it's been more than and 1 hour 50 minutes. It's great actually that we talk about all of these things. And as I said, our mission is to empower people so that they can a you know take care of themselves, b collect data points, and see whenever they are going to have that vocabulary, you know, and the what to ask, what to present to the clinicians when I talk to, so that like uh, so they don't have to visit the doctor more often. And they can get the diagnosis quickly. They can make sure that the treatment is working and there is any data that real world evidence we talk about, right? That treatment recalibration can be done. And more importantly, they can, we talk about this all the time, the care journey, calm the pain when they are in pain, avoid the flare ups,
Mhm.
rebuild the gut and the elevate the gut microbiome, right? If you are going to those care journey, maybe most of the GI issues can be reversed. And again, you can be the pilot of your own health. God's fair, you, me, all the clinicians are all co-pilots, and the patients are the one who have the most skin in the game.
Mhm.
For me, I started this journey because I refused to live life of suffering. My suffering was hijacking my dream of being entrepreneur, building something, doing something impactful. And therefore, I went to the very deeper route about, okay, I need to get out of this suffering
Mhm.
so that I have time on that. I have time to work on my dream. And that was my motivation to do it. And I think it's possible to do it. And and not everybody has the time, resources to get into so deeply as I did. And maybe as a technologist, with the help of you and other team members, we can build this platform for everyone.
Yeah, absolutely.
Yeah.
And quality of life, it is you carry your gut around with you all day long. It is I have seen it's why I love working in GI care. It's so impactful. It's what people can go out to eat. It's travel. It's relationships, right? It's how they proceed through their day with a meeting. It really is it can feel all encompassing. And so if you can feel better in those spaces,
Oh,
it's life changing. Yeah.
just talk to me about it. When I had that, like, oh, I haven't pooped today. If I were to go to poop, right? Is it going to pain? Is it going to be blood? Is it going to be like hard, right? So
Mhm,
it's just very suffocating. It's a kind of mental sitting around your back of the mind. You are not present in the meeting. You are in a client meeting. You're presenting something. You're at a team meeting. You're some portion of your head is behind that. You're not present there. Right? That's and silly thing is, I was talking to somebody, right? There's kind of a taboo or sometimes shame talking about this.
mhm,
And another reason why I talk about this is I'm a bit shameless. So so that it inspired other people to be shameless as well and get the help they need and say reduce the taboo around. Especially because I was reading a research paper, up to 40% of the world population suffer from some kind of functional GI issues.
mhm,
40% is 3.28 billion people. And what worst is they have accepted that living with this is all right. For
mhm,
example, people, I'm from Nepal, people make joke that gastritis is a national disease. Everybody's got it. This is, and I was watching another, there is a Indian movie director, which is a very renowned one. He's from West Bengal part of India. And he's the same. It's the same thing, right? Everybody in West Bengal has some GI issues. That's why they have digestion, digestion, their medication. This at home. Everybody has home. That's not natural or normal, right?
mhm,
Not so. We should accept this disease and live with it. We should actually get rid of it. And on
mhm.
that note, I think hopefully will inspire everybody to live, high quality of life.
Absolutely.